extraordinary pandemic that I think has caught all of us in a way that we never would have expected. Just a few opening remarks today before we jump in. The first, I want to briefly touch on the elections decision that was recently announced last week. First and foremost, while I certainly wish the decision had come down from the governor that ballots would be sent out to all registered voters, I am pleased to see the progress that was made by the Board of Elections on Friday in making a unanimous recommendation to convert polling stations into voting centers for each jurisdiction. I'm also pleased that the governor accepted that recommendation. It's not ballots to every voter, which I think would have been the easiest way to avoid lines, but I think the Board of Elections was diligent in trying to mitigate potential problems by putting forward a unanimous recommendation to convert to voting centers per jurisdiction. So now I think the key moving forward is going to be to educate voters. I know the speaker put forward a helpful video for constituents to see how they can apply for their absentee ballot without waiting on the application to reach them in the mail to go online. And certainly I think our message moving forward will be for everyone to make sure they get those applications in, because the more folks that are mailing their ballots in instead of going in person, the lower risk to everyone. So hopefully over the next few months, we can get that voter education process up and running, and we will take it from there. So the next item that I wanted to make sure to touch base on is the ever-present fight against the idea that health and the economy are two separate things. What we have seen over and over and over again throughout this pandemic is that the state of health in Maryland and the country and across the globe is indicative of the state of our economy. As we all hope desperately to see a reopening and some return to sort of traditional economic productivity, we continuously see in other states and in cases here in Maryland where the state of the virus and the spread of the virus hampers any possibility of a return to economic times that where people were fully employed and we could rely on our strong Maryland economy. So our fight against this virus is the fight to restore our economy. And I think that's the key as we move into sort of the ongoing phases of this moving forward. Since we last met, we've seen sort of varied results in Maryland. We've had several days with over 1,000 new cases. Thankfully, we've seen a ramp up of testing. I think we had a record day last week of 41,000 tests in a day, which was a pretty remarkable number to see. So, we're seeing some positive areas, but we also have some serious places of concern. And especially when we look around us, we see caseloads going up and down. And, we know that in Maryland, we do not have the luxury of saying that it is only about Maryland. We rely on the state of affairs around our borders. And so it is crucial that we remain vigilant. We also had the announcement about schools for the vast majority of Marylanders will be starting the year virtually, which is as a parent of two young ones is a hard thing to grasp. And I know that there are thousands of families out there who are really struggling to figure out what the future looks like. And so these are some of the big questions that all of us are going to be facing moving forward. The last thing that I want to touch base on is simply the state of the budget. We will have ongoing briefings moving forward about the budget, but I think the economic consequences of this experience have been something that none of us could have ever expected. And right now we are watching and waiting painfully with the delayed activity at the federal level. If the federal government does not move forward a package that includes some sort of economic support for state and local jurisdictions who are suffering from lost revenues, I think it's fair to say that we will be facing a budget scenario, the likes of which we in the state of Maryland have never had to experience before. That is the reality. And so we deeply need our congressional colleagues to act and to support states and local governments. We are constitutionally required to balance our budget. We can only turn one place in situations like this, and that's the federal government. So now is the time to act. Last week was the time to act, but if it didn't happen last week, today is better than never. So we will be watching very, very closely to see the activity on the federal level. With that, would like to hand it over to Madam Speaker.
Thank you. Good morning, everyone. It's been a while since we had the work group together, and since that time, Fran Phillips has retired, and we have a new acting Deputy Secretary for Public Health Services, Dr. Jinlene Chan. She has previously was with Anne Arundel County as the Anne Arundel County Health Officer before moving to the Department of Health in 2017. And we all would like to thank Fran for the service that she gave to the state. And we're looking anxious to hearing from Dr. Chan. And at this point, Dr. Chan, if you can go ahead and do your presentation.
Great. Good morning, Madam Speaker, Mr. President, and members of the work group. Thank you so much for having me here. As you said, I am the Acting Deputy Secretary for Public Health Services, and I've been previously serving as the Assistant Secretary with the Department of Health and the Chief Medical Officer, and as part of the COVID response, had initially taken on some of the responsibilities related to standing up many of our community-based testing sites around the state beginning March 30th and moving forward. And as Mr. President stated and recapped, we certainly have come a long way since then. And so I'm happy to be here today and look forward to working with each of you as well as the administration to make sure that we can fulfill our commitments to Marylanders and also to keep Marylanders safe. So thank you so much. I am going to go ahead into my presentation and next slide. There we go. Thank you so much. So I wanted to start out just by recapping a little bit. I know that you have been closely following much of the information over the last month or so, and so just wanted to do an overview just related to the 4 pillars that were outlined in April in the state's roadmap to recovery regarding testing, contact tracing, PPE, as well as our hospital surge capacity. We have now cumulatively reached 1.5 million tests completed across the state. These are the molecular diagnostic tests. And we have actually been averaging about, in the last couple of months, over 24,000 tests a day. And as was just noted, we did hit as many as 40,000 tests reported back to us in a single day last week. And in addition, on August 1st, all of the counties reached the benchmark, as you'll see shortly, of 10% of testing of their entire population. In addition, we have been, since the spring, as you are aware, standing up our contact tracing efforts across the state. And so we actually have over 20,000 cases and 30,000 contacts that have been reached and interviewed by contact tracers at local health departments, as well as with our contracted vendor, NORC. In terms of PPE, which has been a critical foundational piece, one of the key pillars, we have distributed over 72 million pieces of PPE as of last week. And as the discussions about the election in the opening remarks, we are also including supplies for the November election. Early on in the spring, as we saw the number of hospitalizations increase, including the use of ICU beds, we quickly ramped up our capacity across the state and worked very closely with our partners at MIMS and our partners in the hospitals and skilled nursing. And we have approximately now 6,700 surge beds that we were identified and stood up. And so we continue to make those available, and I'll talk a little bit more about that a little bit later. Next slide. We are still currently in phase 2 of the roadmap to recovery. And as stated by the governor just about 2 weeks ago, we're currently in a pause before we have any further reopening as we continue to monitor the trends. And we are monitoring those daily, if not multiple times a day, to look at trends and data to be able to respond. I already mentioned that counties have tested at least 10% of their population as of about a week and a half now, which is important because we want to be sure that there is access to testing across the entire state of Maryland. We've also recently issued additional guidance for nursing homes because that, of course, is where much of the morbidity and mortality centered in the spring, and so we are certainly keeping a very close eye on that and continuing to work daily with nursing homes. And we recently submitted just last week or issued additional guidance to allow them to submit alternate testing plans if they do not have active outbreaks, and so those plans would be evaluated by us. And ultimately, the goal is to ensure that the residents under their care are safe. And then lastly, we just recently updated our guidance and issued a secretary's order to allow for the use of specific FDA-approved point-of-care tests. So these are the rapid tests in Maryland offices of primary care, urgent care, and to be coming in skilled nursing homes. And this order also includes the reporting requirements and other instructions on how people should be able to use those point-of-care tests that are now available to us. So, next slide. So let me talk a little bit about the statistics. I think we've talked about this already, so this is just a graphic showing where we are as of now in terms of percent of population tested for COVID in all the different Maryland counties. Next slide. And this shows sort of the rolling 7-day average percent positive testing. And in a subsequent slide, you'll see that what you were noting earlier, that we were closely watching an increase of cases and hospitalizations creeping up in July. And that seemed to coincide with what we were also seeing in other states. And so we've been keeping a very close eye on it, and really that was part of the decision to halt further reopening because we didn't want to reopen at a time when we were seeing some of our metrics start to increase. But what we're seeing now, and we're very encouraged by the fact that what we're actually seeing now is that our positivity is decreasing. So we are now at one of our lowest positivity rates historically, really in the last few days, that we are now at 3.61 as a state. Another trend that we had noted in the summertime, as we saw the surge or the slight increase in cases in July, was that the positivity among people who were under 35 was nearly double what we were seeing in terms of positivity for people who were over 35. Not to say that over 35 is old, but still that was an interesting dynamic that it was the younger folks, particularly those in their 20s and 30s, that we were seeing greater positivity. And even that metric has actually come down. So the positivity among that age group reached a high, I believe, of around 6.6% in the under 35-year-olds, and now we're looking at 4.7%. So that has also decreased. So that is very encouraging to us. Next slide. And so similarly to case rates and positivity, We are also seeing a slight decline in our hospitalizations more recently. You can see in July that our overall hospitalizations began to go up, but it was primarily in the acute beds. These are just the medical beds, not the ICU beds so much. And so really the ICU beds, while there may have been a slight increase, it really has leveled off, and now, along with some of the other metrics, has decreased. What we saw in July was that the hospitalizations were people who tended to be younger as well, similar, again, reflecting what we were seeing in the wider population. So these are encouraging signs, but I would continue to emphasize that while encouraging, it does not mean that we let our foot off the gas, and it is still incredibly important that we continue measures throughout the state to wear a mask that prevents transmission to others, to keep physically distant, and to wash hands, avoid large gatherings as well. Those are measures that we can take that are simple, that can continue to keep Marylanders safe and to keep our economy open. So that's what we're looking for. Next slide, please. So just briefly, next slide. Wanted to touch on some of the other pillars as well. As you know, we developed and stood up our contact tracing platform, and we are using a Salesforce system that is accessible not only to our own contracted contact tracers, but also for workers and staff who are in local health departments, so that people can see the information pertaining to the residents of their own jurisdiction. There are local health departments that are primary, in which they've chosen to receive all of the COVID cases that are entered into the system for a full investigation, and some other health departments who have elected to be secondary, and in which they receive referrals for cases that might require a little bit more time or a little bit more attention to that particular case. So next slide. And you can see here just generally which health departments have chosen to be primary versus secondary. It really was a choice of what the resources available at the local health department, and also the how they wanted to work with the NORC and the Salesforce system. So this just gives you a snapshot. Next slide. This I won't go into detail because this just gives you a sense, and you can go through it, and happy to answer questions of what the general flow would be for someone who comes into the system. So a positive test result gets transmitted to the Salesforce, which generates essentially a file. And so then that initiates the, that sort of tells the person who, whether it's NORC or the local health department, whoever's primary, to contact that person. And so then it subsequently is a cascade of, trying to contact the person, doing a complete interview, identifying additional contacts that person, the case may have had within the prior 14 days. And there is a texting component if the person chooses to opt in for that, for monitoring for symptoms. So, next slide. So, COVID patient capacity. What this is what I mentioned with the 6,700 beds that we've expanded since April, and one of the primary locations is the Baltimore City Convention Center, the field hospital, which is a true partnership with Johns Hopkins Hospital and University of Maryland Medical Systems. Really a tremendous effort to pull that together. In addition, the Med-Surg team reopened closed hospitals at both Laurel and in Tacoma Park, and have installed advanced medical tents across the state, ready to take patients as needed. So our intent is to make sure that those resources are available and in place for the remainder of the year, and we continue to monitor bed utilization, which I shared with you in a previous slide. So next slide. And I wanted to close by talking a little bit about work that we've done related to targeting underserved populations and minority populations, which is really critical as we look at the impact of this pandemic. It is something that we recognize the challenges that have presented themselves previously in terms of access, and so we really are honing in on this particular area as well. So our Office of Minority Health and Health Disparities have provided kits and have participated in plans and also in activities related to outreach to African American populations, the Latinx communities, and the Haitian Creole communities as well, particularly in the Eastern Shore. And a lot of their focus has also been in terms of connecting to community groups, to key stakeholders in jurisdictions throughout the state, including the MOTA partners, which are an important link for us to be able to identify areas of need and to ensure that whether it's contact tracing or testing, that we make sure that those resources are deployed and that we are able to identify individuals who may have tested positive and to, again, mitigate the potential spread of infection within those communities. Next slide. This outlines a couple of other things, or a number of other things that they're doing in terms of communication. We're looking at working with influencers in the community and important community groups and stakeholders as well. Mobile public health education, I believe we are working with the NAACP, the Baltimore City chapter there, and so there's a lot of other efforts that are being undertaken on this front, and so I won't go through each bullet point, but just want to outline those, and that this continues to be an important area of focus for the Maryland Department of Health. So I will stop there. I think that is my last slide, and I'm happy to take questions.
I believe our first question is from Senator Kelly, Chair of Finance.
Good morning, and thank you, Dr. Chang. I'm concerned particularly, and welcome to your new position. I hope you have success at it. We have a real problem with nursing homes and assisted living facilities trying to meet the requirements, and the requirements sound reasonable, except it isn't clear how you can expect them to pay for the additional testing that is needed. I understand that the health department had negotiated a weekly testing plan for $40 per test, and they were to contract with the University of Maryland Pathology Associates to get this work done. As it turns out, I'm looking at copies of mail sent to some of the nursing homes in my district where the University of Maryland Associates or Pathology Associates are saying, unfortunately, we are unable to facilitate a signed contract by the state of Maryland's deadline of Friday, August 2020. We are working to onboard facilities as quickly as possible to meet the rising demand, and will reach out to you in the coming weeks. And that's with an S on it. That could be months, or additional capacity becomes available. We look forward to working with you in the future. Now, it's problematic that considering how many of the patients in these facilities are on Medicaid or Medicare, and bucks aren't there in the first place. I know the state's broke, but these people are even broker. And now that you tell them how they must come with an entity that is saying to them, and I don't know if the entity has also said to you and to the department, they are not ready to give the assistance and to go to contract. And so instead of the $40 per test that you had contracted for, they still are back needing to use other labs at $75 to $100 per test. Could you tell us where relief will be with regard to this and what they can do in the interim until they can't do with nothing been required. Thank you.
Thank you, Senator Kelly. So, you know, when we began working with the nursing homes in the spring, you know, we were in the middle of, I would say, more of a crisis at that time with the pandemic, still fairly new as we ramped up our infrastructure, really across the state, not just state-supported, but, you know, healthcare facilities were really working to ensure protection of the residents. And I think that that's the strong message from our Secretary Neal, that, you know, we are now in August, and so how we can continue to support, you know, with the work that we've been doing and is to provide access to labs like the University of Maryland, Baltimore, and so we'll certainly look into where the challenges may be there. In addition, there is $10 billion that the federal government is going to be allocating to nursing homes as well, and so there are dollars there. And the other component that is coming down the pipeline soon, we don't have a specific time frame yet, are some of the point-of-care tests. And that, coupled with some of the alternate care or alternate testing plan guidance that I alluded to that was issued last week, you know, we are trying very hard and work with the nursing homes individually and as a group daily to certainly address some of their concerns, but we believe that, you know, this is important, and ultimately it is about trying to protect the health of the residents and prevent some of the morbidity, mortality that we know can happen and has happened, unfortunately, as a result of COVID-19 infection.
Okay. Senator Kelly, you okay?
Well, I hear, but I know everybody has good intentions, and maybe the orders didn't emanate originally with the health department. They might have come from higher up. But what are these people to do? Our most vulnerable citizens are there. They're very susceptible to COVID-19. They have a lot of comorbidities, and the nursing homes and assisted living facilities can't print money, and it isn't clear what they are to do. They are apparently, as of Friday, once we get to the 14th and the date by which they were to contract has arrived, in danger of being in violation of their arrangement with the state. But it's an unfair arrangement that can't be implemented. And somebody should tell them what to do in the interim, or make sure that they get additional resources. We don't need nursing homes and assisted living facilities closing at this point in time. They're needed now more than ever, and they can't do with nothing. I know it isn't your fault, Dr. Chang, but tell us what you would recommend that we say to them, or what you can say to them that would bring some relief during this interim.
Well, this is a requirement, you know, a recommendation and ultimately a requirement by CMS that was issued back in May to the skilled nursing facilities for weekly testing of the staff. And so for the residents who are there, testing should be available, and we have outlined guidance for what testing of residents should look like. It's the weekly testing of staff that we have certainly worked very hard in the last few months. You know, one of the important resources that you alluded to with the UMB lab, that is because, as we saw related in July, you know, with some of the long turnaround times that we were seeing with commercial labs, this is the reason why we want to have our own capacity. And so to the extent that we're able to support, we will try to do that. And we are continuing, as I said, to talk with our partners. They are our partners, to understand where the challenges are and support where we may be able to. However, this has been guidance and information that has been, and the requirement has been in place since May.
Okay, but the lab is saying to them, they are not prepared to contract with them under the terms that the health department arranged for. So I won't go on, but this is a concern that you're putting a burden on, which can't be met given the status quo. Thank you.
Okay. Next up is Chairwoman Pendergrass.
Great. Thank you, Madam Speaker. Welcome, Dr. Chan. It's nice to see you.
Nice to see you.
I've been struggling with the numbers, the positivity numbers for a fairly long time. And it's now clear to me that the Hopkins numbers show a higher positivity rate than the state numbers that you get, that you post. Also, my husband is a mathematician and he gets a different number. Also, if you add the positives and the negatives, which is now my level of mathematics, you get a number that is not related to the number of tests that you're using as your number of tests that day. Can you explain why this is so not straightforward? It seems cryptic or something. There's something missing.
Well, you know, I would say that so when you deal with data, and you know, as your husband and you obviously appreciate, there's so many potential nuances. And so what we have tried to do, and we've been consistent at the health department since the very beginning, is we tried to pick numbers that we thought could be as consistent as we can make them. And so, for example, we report out on tests reported to us on a single day, to report out on the positivity and cases. And the reason for that is because if we were to use, for example, test collection date, the results will come back over the course of several days or a week, and so the numbers would be constantly shifting. And I think our feeling is that because of that, it would be perhaps more confusing to explain the constant shifting in the daily numbers. And so we selected what we thought would be the most consistent reporting number for the positivity, which is number of reported test results in a given day. So, and that could vary then in terms of when the test collection date occurs, which is a different way to look at the numbers.
May I interrupt you? Because it seems to have sort of gone by me quickly. My brain isn't processing, apparently. You're suggesting that you're not comparing the number of tests reported to the number of positives and negatives reported?
No, meaning what we look at on a daily basis is we look at all of the test results that are reported to us, and then look at which ones are positive and which ones are negative. And so that's what is reported.
Stop there for a minute. If you look at the positives and you look at the negatives and you add them up, shouldn't they be the number of cases that are reported that day, the number of tests?
Yes.
And they're not.
Okay. I'll go back and do some of the math. There may be some data reconciliation issues as well, and I believe there is some element of looking. There may be some tests that are not. I don't know if they're indeterminate, or there may be other matters that might.
Well, if there is another category like indeterminate, it would be useful to see the number that's indeterminate, because you would like the positives and the negatives to add up to the total number of cases. That's step one. Step two, your positivity rates are lower than both Hopkins and my husband seem to get on a daily basis. Mm-hmm. Why do you think that is? Or could you look into it and get an explanation that would be clear to somebody? It might take more than me to understand it. I'm okay with that. I'm still stuck on the pluses and the minuses not adding up to the total, frankly.
Right.
But you'll get that for us.
Yes, ma'am. We'll provide that more detailed explanation. I would say more generally that, you know, what we are seeing right now, not only at the state level, but at the national level, is that there are multiple data definitions and multiple ways in which states are handling their own data and reporting out data, which provides certainly a very inconsistent, you know, it makes it very difficult to compare apples to apples. What I would say is that in Maryland, we have been consistent from the very beginning. And so in terms of the numbers that we're reporting out, we have not changed our methodology from the beginning of the pandemic to now. And so we believe that our numbers, you know, when we look at the trends going from the spring into the summer and now towards the end of summer, that the consistency is there. And so
there is consistency. You consistently don't add up on a daily basis to the number of tests. I mean, and that in part, that can explain why the Hopkins data is different. That's what I'm trying to figure out. Why is it that, you know, there's a fixed number of tests that are reported and they should add up somehow to the same number of as the results?
Right, and we are having conversations with Hopkins and others as well. I think that, again, it goes back to which data is being used probably. They ultimately, the data that they use come from us as the source. And so, but we will provide a little bit more granular explanation of the differences.
And interesting that you use the word granular. Are you the person who helped craft the answer to my original question on granularity some months ago?
I don't believe I was.
Okay, well, the question had to do with, wouldn't it be helpful? Because we can see on some days when the number of testing is very high, you get a fairly consistent percentage and you see that it looks the same as it looked 5 days ago. And on some days, it's substantially higher. And then on some days, it's substantially lower. So the rate can vary tremendously from one day to the next. Mm-hmm. And there is some thought on my part that this might reflect when we test nursing homes, when we test chicken processing plants. I'm not sure what the data, what it would be. Do we have any granularity on what tests we are running, what the population looks like for the tests that we're running? In particular, the source. I know you're doing some amount of racial separation, but I'm actually thinking about the source, where it's coming from, not so much who it's coming from.
Right. No, that's a great question. And I think that we're looking a little bit deeper into that right now, and we're beginning to get this information through CRISP. It's imperfect because, of course, the feeds that we get are directly from the laboratories themselves, and the laboratories don't usually collect exactly where the specimens may have been collected. But we are looking at that. It is a question of interest to us.
Would you know that you sent the nursing home tests from a particular nursing home to a particular lab?
For the ones that we have been involved with, we have been keeping very close track on that, yes.
So that would be a level of granularity that could have been included, that could give us some picture of how that's going.
Yeah, and we continue to work with the nursing homes on that. There is actually a fair amount of logistic challenges that we continue to work through, and just to make sure that our information and data is correct. So we are working through that information as well. So
it would be nice for me to understand where that is coming from on a daily basis on the website. But I'll leave it there. Thank you very much for your patience, everyone.
That's fine. Let me make sure I understand your question, if I can, Chairwoman. You are interested in particular the sources where the tests are being completed?
The kind of source, whether today we've done an unusually large number of nursing homes, mm-hmm. or whether we've done an unusually large number of chicken processing facilities, or a place where you might expect it to be causing the rate to be higher, as opposed to just geography, for instance, which is good. I love seeing the counties, but it's just another thing that would be helpful in explaining where it's spreading for the layperson who looks at the website.
I understand. And, I would certainly caution everyone to, while we're looking, of course, daily at our daily positivity, daily hospitalizations, and all of the other metrics, it's really important to look at trends over time as well. And so that's why, looking at 7-day averages, because again, for stability's sake, we do report out using, on cases using the date of report to the health department. And so when you look at the 7-day average, rolling average, it helps to understand perhaps better the trends. But I do understand your underlying question of whether a particular testing event may contribute to a higher positivity in any given day or week. So
thank you.
We'll try to look and see if we can provide a response to that.
I don't want to belabor the point, and I know we're President Pro Tem Griffith will be the next question, but just, I've switched over. I used to look at the Maryland site every day, and I still will check it, but now my everyday look is at covidactnow.org. It has the 5 clear metrics that change on a daily basis by county. Maryland's contact tracing data seems to be not as robust as other states. But the positivity test rate is a big difference. Today we're at 3.6 on the Maryland site, and then at COVID Act Now we're at 5.3, which obviously that's above the threshold of stability. So I think clarity on this question is really crucial as we move forward.
Yeah, and I would say that again, with all of the various sites, whether it's Hopkins or COVID Act Now, Harvard, there's a lot of different metrics and a lot of different methodologies, which can also kind of confuse what numbers we're looking at. And so one of the things that we would like is really a common definition that we could then use to compare apples to apples. So, but, I think that there are a number of different sites showing different numbers, but again, it does not make them wrong, but it does not necessarily make ours. We picked a methodology that we believe is the most correct and what is most stable for us.
President Pro Tem Griffith.
Thank you. Thank you, Mr. President, and good morning, Dr. Chan. I just had a quick question. During your presentation, and I appreciate the updates you provided on the PPE distribution and where the state is in terms of providing resources. But my question more is, you mentioned, for example, the election workers and that you'll be working with them as we prepare for the general election. Can you talk a bit about what guidance or advice we're giving to election workers or others about safety of staff, volunteers, what kind of advice the state is providing for organizations as they prepare to reopen and get back to business?
We have worked as the entire health department has worked with a number of different entities, organizations, sectors, private and public, to talk about their unique settings and situations and operational needs to implement measures that will be the most protective of their own staff as well as the public that may be coming in. And so, I think that the basic tenets of that, the governor expanded the mask order short while ago, 2 weeks ago, and that has been a very critical component of it, and so it is about the same components that we continue to emphasize for the public, and the same at least principles apply when you're talking about retail or elections. It is about masking, it is social distancing or physical distancing to try to maximize the amount of space between individuals and to prevent large crowded gatherings of individuals, and then to provide opportunities for hand hygiene. So whether it's whether it's hand sanitizer or hand washing, that's really important. We continue to rely on the CDC as well for some of their guidance in particular settings, and so we share that with individual organizations and entities and discuss as needed if they have questions.
Okay, so thank you for that. And I know I had seen a while back, for example, some guidance, and I don't even know who was the source. It might have been a CDC for beauty shops and nail salons and things like that. I guess I'm just wondering if the state is going to produce any written guidance or direction specifically related to election safety and considerations in that regard. And I'm pleased to hear that we are sharing with retail and, I'm assuming daycare and other entities guidance and direction, but would love to know more specifically if we are providing directed guidance for boards of elections, for example.
So the CDC has fairly detailed guidance related to election sites and for voters as well. And so if we feel that there needs to be an augmentation, we'll certainly work with the State Board of Elections on the questions to address questions and concerns that may arise.
Thank you. Thank you, Mr. President.
Speaker Pro Tem Sample Hughes.
Thank you, Madam Speaker, and good morning, everyone. Dr. Chan, congratulations on your new role, and look forward to working with you as well. My question relates to a document that is called Skilled Nursing Facility Advanced Beneficiary Notice of Non-Coverage. I know it's a mouthful, but are you familiar with that document before I go further?
I am not familiar with that particular one. If you detail it more, we're happy to provide what information I'm happy to provide what information I might have, and also then certainly follow up with your office.
Okay, so let me share where my concern is. This document, the Skilled Nursing Facility Advanced Beneficiary Notice of Non-Coverage, is a document that is going out to persons in the nursing home, and it goes specifically to whoever their loved one is that's handling their business on the outside. But it's a document that is being certified mail, and it pretty much outlines that when someone has been tested and tested positive for the coronavirus, the COVID-19, that they are then put on Medicare. And then when they are no longer positive, they then go back to Medicaid. The letter has three options on it, and it speaks to whether or not you want to continue with Medicare, or would you like to pay out of pocket $400 a day for the skilled nursing care, or not. But my concern is that we have so many people in the nursing home that are kind of in that back and forth way of having to handle this situation, that is almost as if it's an eviction letter, the way it's written, the way it's sent out as a certified document. And so your average individual has no understanding of what that document is doing and how it impacts their loved one in the nursing home. My suggestion is, in fact, if this is a federal Medicare requirement or state communication requirement, that there needs to be communication to their individual who's handling their business when they are tested positive, that they're also known that they're going to be on Medicare services for skilled nursing facility while at the skilled nursing facility, because it is really unnerving to know, number one, we still can't see our loved ones in the nursing homes. But then to get a eviction letter, that's a concern. I think that there may be some way to ensure that everybody is of the understanding what that letter does and what it means and how it impacts their loved one's care in the nursing home while we are under this COVID-19 pandemic, given that's the reason why these letters are forthcoming. So any assistance you could provide on that end would be greatly appreciated, because I must say it is something that can really get under someone's skin, because they want to make sure that their loved one is taken care of and not evicted within 2 days or having to pay $400 out their pocket. So I just want to give you some insight. I have the document, and I just want to let you know that our Marylanders are being faced with this as an issue.
Great. Thank you so much, Delegate Sample Hughes, for raising that. And if you have a copy of the letter that you could share with us, we will certainly look a little bit deeper into it and provide more information back to you and the constituent.
That would be greatly appreciated, given the fact, I think we could do our due diligence through the nursing homes and help these families as they are working through this, and their loved ones are testing positive, that we can give them some insight as to what document is and what it would potentially do to their loved one while they are being in the skilled nursing facilities. At least in our state, we can at least help that.
Thank you.
Thank you.
Next, I believe we have a question from Senator Pinsky, Chair of Education, Health, Environmental Affairs.
Thank you, Mr. President. Welcome, Madam Speaker, and also Dr. Chan. I've got two questions, one on large gatherings and also on schools. And following up Senator Griffith's line of questioning, she asked about the State Board of Elections. Let me ask you about schools for a moment, Dr. Chan. As the Senate President said, we're going to probably have almost all jurisdictions start virtually at the beginning of school. But there's been a long conversation and a deep conversation about under what circumstances should in-person schooling begin. So I guess my first question is, has the State Department of Education or the state superintendent herself solicited from you the appropriate metrics that should be used to decide when to open in-person instruction?
So we work very closely, of course, with Superintendent Salmon and her team at MSDE, and have been doing so on a number of areas, including in child care and other metrics, other areas, including, of course, schools. And so it is a discussion of what ultimately the public schools may be able to do. And there is CDC guidance out there as well, and we certainly look to that as some of the information, as I alluded to, with the Board of Elections and other guidance that is put out there in terms of what measures need to be considered as a school system considers in what format they may be able to provide educational services in the safest manner possible.
Yeah, Dr. Chan, I appreciate your answer, but I don't think you answered it. The question is, have you been in discussion with the State Department of Education on very clear, explicit markers, metrics, to guide whether schools should allow in-person instruction? It's a fairly straightforward question.
So, I think that the metrics are really something that when we look at the statewide one, similar to what I shared earlier in the presentation, looking at community spread, looking at positivity, and those are some of the measures that we are looking at, not only for schools, but really when we look at reopening as a whole. And so that is certainly part of our conversation, yes.
Including the actual numbers, the thresholds that would allow students to return in person?
So, there's not been any guidance specific to thresholds for which it is safe per se, and it really is, a combination not only of the metrics that we're looking at in terms of community spread, but also looking at how we can safely provide physical distancing, transportation of students in a safe manner, protection of staff in similar ways. So there's also operational considerations that must be part of that discussion.
Okay, well, I won't belabor that. Just to understand that many school systems of the 24 are unclear on how to proceed in terms of transition to in-person, and I think they're looking for guidance. And that guidance from the State Department of Education and the Department of Health, I think would be greatly appreciated. Let me go to the second question. Other than a club in Baltimore City that was closed because of having a large gathering, I've not seen any evidence of enforcement of large gatherings, whether it's in backyards or in communities and streets or at establishments where the organizers or hosts have been cited, fined, or in fact arrested. And I guess my question is, there's been a fair amount of anecdotal evidence of groups of 200, 300, 400 that have been meeting outside, in some cases inside in others, where they're not wearing masks, where they're not social distancing. And I guess my question to you, because you're the one who mentioned the importance of not having large gatherings as well as not wearing masks, is that a voluntary request, or is the state government planning on enforcing it? If that's a key component to stopping the spread, it would seem to me, if there is a large gathering of some hundreds of people who are endangering not only their own lives, but the lives of the people in their own family or community when they return, that's a public health risk. And I guess I just haven't seen anything about enforcement. And I would assume that the Department of Health would be in the forefront of speaking to the governor about having true enforcement. You probably read in Washington, D.C. over the weekend, there was a gathering of 400 people, 21 people were shot. The police were there, but didn't try to stop the gathering. And I'm trying to understand how we're going to prevent that in Maryland and what role the Department of Health is going to play in that enforcement.
No, thank you for that question. So we have been very closely involved working with the Maryland State Police in developing enforcement guidelines, both for the more recent expanded masking order, as well as other governor's orders, which have the effective force of law under this emergency setting. And with that, we also have been working very closely with all of the local law enforcement and local health departments, and as appropriate with local liquor boards and others as part of enforcement. And again, that varies depending on the jurisdictional agencies and organizations that are involved. And of course, dependent on the setting, whether it's an establishment that serves alcohol, for example. And so that has certainly been happening. And so there are enforcement with large gatherings and, work with the local law enforcement and local health departments. I can go back and provide a little bit more detail on that for you as a follow-up.
That would be great. If you could tell us either today or at a latter time, how many events and large gatherings have been closed down and shut down, and how many enforcement actions have taken place, I think that would be very illuminating. Thank you.
Thank you.
Yeah.
Madam Speaker.
You have a senator next.
Oh, my apologies. I didn't see that. Yes, Senator Lamb.
Thank you, Mr. President, and congratulations to you, Dr. Chance. Good to see you moving up into this role. And as a graduate of our residency program, in my other hat that I wear at Hopkins, it's great to see a graduate of our program ascend to that position. So, congratulations. I wanted to follow up on Chairperson Pendergrass's question about the positivity rate. So, on one hand, there is no standard methodology for calculating the positivity rate. and to try to answer her question as well, there are differences between, obviously there are differences between how these are calculated. My understanding is that Hopkins uses a moving average in calculating the positivity rate. What that means is that they're not looking at the daily number of new cases that are being resulted and the daily number of new tests that are being done, but it's a moving average of the number of new cases and the moving average of the number of new tests that are done. And that's how they're able to calculate their positivity rate. And I think that's also how COVID Act Now is populating their numbers too. So, there's that big difference in how the positivity rate is being calculated. The second one is that I think the state is counting just overall number of tests that are being done, whereas I think Hopkins and others may be trying to wean out those who may have been tested more than once, right? And so, I think there are people that have been tested more than once, and obviously, that can contribute to a reduction in the positivity rate too, if they are testing negative in all those times. So I think those are things that are important to bear in mind. I think it would be helpful, though, to have the actual methodology that the state is using to calculate the positivity rate. Is that something that MDH can share with us, or the actual formula that they're using to calculate this positivity rate? Because there are a lot of discrepancies and questions here.
Yes, no, absolutely. And, again, our team has had multiple conversations with the Hopkins Coronavirus Resource Center team as well in terms of the different methodologies. And they've actually stated to us that, our methodology is not wrong, it is different. And they acknowledge the differences in our methodologies. And I would also note that from some of the numbers that CDC and the Coronavirus Task Force has put out, we are using similar methodologies as they are, where we are using total positives divided by total tests reported in a day. And so certainly we can get into a more in-depth discussion perhaps offline in terms of the epidemiology and how we actually calculate the specific metrics, and whether it's an average over 7 days or a 7-day rolling average. And so ultimately I think that when we look at that, the trends, it's important to also look at trends and then couple it with, the other metrics. And so I would certainly caution that, and I know that you're very well aware that of focusing on a single metric, and we certainly are looking at as much as we can, the overall picture of the impact of the disease on Marylanders. So,
and yeah. I think that brings up an important point, which was the next one that I was going to make, which is the positivity rate is only one metric, right? That should be looked in a spectrum of other metrics as well, because the positivity rate can be affected by the number of tests that are administered, right? So the more tests that you administer, and I know that's a goal of the state, and that should be, the larger the increase in the denominator, and overall the reduction in the positivity rate. Right. And so in a way, maybe even hospitalizations or the rate of ICU usage might be a more standardized or normalized metric, so to speak, because one would assume that the criteria used to admit patients into a hospital is not necessarily changing on a daily basis, whereas the number of tests being administered would change on a daily basis. And so I think that's important to bear in mind, because there's been a laser focus on positivity rate, but that's really just one metric, and it's a metric that's not a perfect metric. There is no perfect metric to begin with, right? And so it needs to all be viewed in a spectrum of the other data that's available to us when we're trying to look at this as well. But I think it is important to note, and I think both on COVID Act Now, which I'm looking at, and also the JHU data, there hasn't been a dip below the positivity rate below 5% since July 8th at Hopkins and July 9th at COVID Act Now. So, while there is a difference in how these are calculated, there's certainly, a consistency amongst these other, data sources that show that we are consistently above 5%.
Mm-hmm. Well, I think that, as to Chairman Pendergrass's question, we will provide some more information looking at both our methodology and the Hopkins methodology. They are different, which contributes to the difference in calculations.
Right. I think the other thing to bear in mind is that, while testing has increased, which is good, contact tracing, I'm still hearing that the turnaround time can be prolonged in the community, especially the community-based tests. So if someone's getting a test on at LabCorp or at Quest, that the turnaround time could easily be 7 days. It could be 14 days. I've had patients or employees that have not gotten their test back for, over 14 days, I think about 18 days. And so, at that rate, while testing is up, without a proper turnaround time, clinically, diagnostically, it's useless. And even from a contact tracing standpoint, anything over 3 days, you're not reducing the transmission rate to make contact tracing effective. So it becomes effectively worthless as well. Are there any steps being taken to address the turnaround time of these tests?
Absolutely. When we began to see the turnaround times creep up over the summer, and really that we know that was the impact of the huge surge that other states were seeing that was then really landing on these commercial national labs. And so, yes, we have been seeing very long turnaround times. And so we had a lot of discussions with those commercial labs. And in fact, they have come down. So LabCorp now has a median turnaround time that we're seeing here in Maryland of around 2 days or less. In some cases, there are still some other commercial labs that are still much longer than we would like. And so, yes, to your point, a long turnaround time does not help that individual and doesn't help our overall contact tracing efforts to continue to mitigate and prevent the onward transmission of the infection. And so, early on, one of the strategies that we did, and we are doing a number of different things to try to address this, but we have, as was discussed earlier, and working with the University of Maryland, Baltimore to enhance the capacity there, and we've also contracted with in-state labs to, again, try to at least minimize the amount of the turnaround time that might be attributed to just transit in general. And so those are some of the strategies that we've taken to impact that. But knowing that many patients still access testing through their primary care physicians, through hospitals that may still use commercial labs, those are very important conversations that we continue to have with the national chains as well. So we are encouraged that the turnaround times have decreased. I believe that both Quest and LabCorp have committed to continuing to expand their overall capacity nationally, which will help not only Maryland, but of course around the country. And as was noted earlier, we don't have closed borders, and so if we can expand turnaround times and testing across the country, then that will also help Marylanders indirectly. So, but yes, your point is well taken, sir.
My last question about testing is, I know that the governor had entered into, I guess, an agreement, so to speak, for a multi-state compact to enhance testing capacity, I guess, right? And my understanding is that this is an agreement for rapid antigen tests, right? So these are actually the point of care tests that try to turn around test results within 15 minutes or 20 minutes. But my understanding from these rapid antigen tests, these point of care tests also, whether it's FDA or others, do recommend that there be a molecular test, a standard nasal swab test that be done subsequently afterwards, right? Because these point of care tests are fraught with potential for false positives, false negatives. And we noted that with what we saw in the Ohio governor, who I think initially had a rapid antigen test first, and then subsequently reported back a molecular test that was initially positive then negative on the molecular test, right? And so, while the rapid antigen tests are just one piece of the puzzle, it's not, I think a bulletproof solution to all of this. And I think it's important to note that the false positive and false negativity rates of the rapid tests are fairly high, right? Aren't they higher than the standard molecular nasal swab tests?
Yeah, I think that so absolutely, and our strategy is not unidimensional. We are definitely looking at all the available tools to be able to apply them, and understanding that every tool that we have at hand that's available to us has its own limitations, including, honestly, molecular testing. I mean, the main limitation with molecular testing you honed in on is the operational and logistics of actually collecting specimens on a massive scale and getting a turnaround time such that we can take action in a timely fashion. And so that's a major limitation on the molecular PCR-based testing. And so the rapid tests allow us, is another tool that we can acknowledge the limitations, and so the sensitivity and the ability to accurately detect a true negative, I guess, is down towards 80–84%, depending on which actual platform is being used. But if there is a positive, and yes, in the case of the Ohio governor, he actually had a false positive, I think, initially on a Quidel test, is that the positives we generally can, it's much higher, the specificity is much higher, and so in the 90, 95, 90 or plus, I believe, percent. And so we're really, we need to understand what the limitations are of those rapid antigen tests and use them as screening with then appropriately a follow-up molecular test as the situation calls for. And so,
right.
Again, the compact is our way of ensuring that we have that tool in the toolbox ready to use and be available for Marylanders.
So then I think it's important to note that, when you're citing the test results on your website in the future, to distinguish between the rapid antigen tests versus the standard molecular PCR tests then, because there are some differences there, and how those are calculated could swing the numbers one way or the other. And then I guess my last piece, sorry, were you going to?
I was just going to say we do not report currently the antigen tests as part of our numbers.
Okay. I had a constituent in a nursing home who tested positive for COVID, and the family said that they were not ever told by the facility of any periodic COVID updates, and that's required by the secretary. So I'm wondering if you can just, articulate or maybe go back to the department on, what's being done to proactively ensure compliance with the governor's and the secretary's nursing home order to keep families informed.
No, that's important, and we'll continue to emphasize the importance of making sure that families are informed, especially in this time when they've had such limited access because of trying to protect the residents in the existing facilities. They've had such little ability to interact with their loved ones, and so keeping informed is really critical, and so we will certainly go back and reemphasize that message. So thank you for letting me know.
Okay, thank you. Thank you, Mr. President.
And I believe our last question is from Vice Chair Pena-Melnick.
We're trying to unmute the Vice Chair.
Am I unmuted?
I can hear you.
Okay, beautiful. Sorry. Good morning. Given the fact that the University of Maryland Pathology Associates is now telling nursing homes that it cannot contract with them, will the Maryland Department of Health grant the nursing home and the industry an extension for compliance? Because my understanding is that the feds only test if the positivity rate is 5%. And I understand that you said that according to Hogan, the positivity rate in Maryland is 3.6%. So are they going to be able to get some help and some time to be able to comply with the rules since they were changed?
we're going to continue to have discussions with our skilled nursing partners so that, to understand where the challenge is and what is needed to be able to meet the requirements by CMS. There is, as I understand it, $10 billion that the federal government has allocated to support skilled nursing facilities in all of the various work, including testing that they're doing to protect their residents. And ultimately, I think for the Secretary and for all of us, really, it is about trying to make sure that that residents are protected and that we focus on their health and safety. So we will continue those discussions with our skilled nursing partners.
Thank you.
All right. Want to thank you. Thank you for coming today and presenting. And I'm sure I saw you taking notes that some of the questions that need a follow-up, we'll be in touch with that particular member, and the member who has their constituent letters will get that to you. I'm sure there'll still be that communication.
Right.
And I just want to thank you. I know it was a lot today, but we appreciate it. It was very, very helpful.
Thank you.
You're quite welcome. And I know that as terms of the work group, we, in terms of the next meeting, we're on like a stay tuned mode. And that's something really comes up that immediate attention, we will, I don't see having another meeting this month. And so we will let you know how September will be in enough time. So, Mr. President.
Thank you, Madam Speaker, and thank you as well, Dr. Chan, for being here today. We appreciate the information enormously and look forward to the ongoing communications. Two small things that I failed to bring up at the beginning. Just want to bring folks' attention. The Judicial Proceedings Committee recently published 2 work group reports. There was a lot of work done on these subcommittees to look at the issue around housing and evictions. And Chairman Smith worked alongside with Senator Hedelman on the housing and evictions report and recommendations, as well with Senator Carter on criminal justice in the courts. Both of those reports are now available on the website and contain some very substantive recommendations that hopefully the administration and in some cases the judiciary will consider adopting. And then finally, tomorrow, Senator Pinsky and I will be hosting a conversation with superintendents about the future of reopening and a path towards reopening. And that will be tomorrow at 10 a.m. So with that, thank you all and stay safe, masks on, and look forward to seeing you all soon.
Thank you, everyone. Thank you again, Dr. Chan.
Thank you, Madam Secretary.